Pericarditis can be a really challenging condition to diagnose. It is inflammation of the lining around the heart called the pericardium. In acute cases, this could be mild and self-limiting, but there is a proportion of acute pericarditis where the inflammatory cascade in the body is triggered, and this can progress to a recurrent pericarditis state, which can be challenging for the patient to endure and can be challenging to treat. My name is Shadi Ayub. I'm an imaging cardiologist and associate professor of medicine at the Mayo Clinic. And the article that I'm excited to speak to you about today is called IL-1 Inhibition for Constrictive Pericarditis, a Novel Therapeutic Approach. That's going to be coming out shortly in Mayo Clinic Proceedings. So what are the key takeaway messages from this article? The first is that IL-1 inhibitors, such as rilonacept, may have a role in constrictive pericarditis based on the clinical improvements seen in the patient in this report. And this may be a suitable indication for IL-1 inhibitors in addition to the current FDA-approved indication for recurrent pericarditis. The second takeaway message from this article is that the timing of IL-1 inhibitor therapy for this new indication, constrictive pericarditis, matters. And particularly if given early in the inflammatory phase of the condition, it's likely to have a greater benefit than if given later in the disease process when pericarditis may progress to fibrosis or calcific stages. Current treatments for recurrent pericarditis include what's called triple therapy. So medication called colchicine, non-steroidal anti-inflammatory drugs, and high-dose steroids that start off at a very high dose and taper very slowly. And these, as you know, can be associated with significant side effects. For cases where there's constrictive pericarditis, which is a subset of pericarditis that's more challenging and associated with heart failure, particularly if it progresses to the calcific stage, surgery with a more complicated procedure called pericardiectomy is often needed to help the patients. And this is where IL-1 inhibitors came in. The Rhapsody trial, which was reported in 2021, demonstrated that 96% of patients treated with IL-1 inhibitors, which is a once-weekly injection and a biologic agent, 96 of these patients remained free of recurrent pericarditis. And as such, the FDA approved IL-1 inhibitors, specifically rilonacept, for the indication of recurrent pericarditis only. So in this particular case, I saw this patient in the clinic who's a 56-year-old woman who was receiving therapy for lymphoma with another biologic agent called rituximab. And she had been troubled by recurrent heart failure and recurrent pleural effusions requiring a thoracentesis each week for the preceding 9 months. And it was not identified that she had pericarditis or constrictive pericarditis for that matter. An echo was obtained, and as you can see in figure 1 of the article, all the constrictive features on echocardiography were seen, including annulus reversus, abnormal septal shift, expiratory hepatic diastolic flow reversals, as well as the classic strain features with decreased motion of the lateral wall due to tethering with constriction. Her MRI, shown in figure 2, showed quite marked pericardial thickening, 4 millimeters, which often says that patients need steroid therapy and would not have resolution of their condition without steroid therapy. Importantly, her CT scan showed thickening but no calcification. Now, unfortunately, this patient had a severe reaction with previous steroid therapy, including psychosis requiring hospital admission, so we did not have the option to use steroids. We discussed the standard surgical approach in these challenging cases with severe heart failure due to constrictive pericarditis. However, the patient who was going through a lot with cancer therapies and actually went on to go into full remission was not willing to proceed with open heart surgery. And it was in this context that we considered rilonacept, which is the IL-1 inhibitor that we just discussed. Now, the FDA only approves it for recurrent pericarditis, and technically this patient had constrictive pericarditis. However, the MRI did show an inflammatory component, and after going through a lot of steps to get authorization and approval for this medication because it wasn't under the classic indication, we were able to get her on this therapy. As soon as the patient started this treatment, her pericardial inflammation markers improved with normalization of inflammatory markers, including CRP. And most importantly, she had no further need for recurrent thoracocentesis. So she was having weekly pleural taps, and once on rilonacept, 3 months into the course, she required no further pleural taps. And this was a significant improvement for the patient. So she went on to go into remission, fortunately, with her lymphoma, and the pericarditis was under control. Now, repeated MRI at 1 year's time showed ongoing pericardial thickening, which suggests that there was perhaps a fibrotic component in addition to the inflammatory component of the pericarditis, despite her symptomatic and inflammatory marker improvement. Now, at that stage, we were discussing perhaps a slow taper of rilonacept. However, the patient went on to discontinue this medication because of concerns for immunosuppression. And as such, after stopping the therapy, 3 weeks later, she had recurrence of pleural effusions and required hospital admission and further taps. So the proof was in the pudding. This medication, despite incomplete resolution by imaging criteria, had helped her symptomatically, and restarting the therapy had resulted in remission of symptoms again. So the main conclusion of this article, and the reason for us wishing to publish it, is to let our colleagues and readers know that IL-1 inhibition may have therapeutic benefits in constrictive pericarditis in addition to the currently approved recurrent pericarditis indication. And as mentioned, timing of this therapy is very important. If given earlier in the phase when there's a primarily inflammatory component, the patient may have more benefits than given later in the phase where the process may be predominantly calcific and there might be less inflammation for this therapy to work on. So, future studies are needed. We need to better understand how this therapy, IL-1 inhibition, may fit in the role in therapy of constrictive pericarditis. So case series as well as prospective studies are needed. And the second question that would need to be answered would be, what stage of disease, what imaging marker levels would be appropriate to say a patient may benefit with an inflammatory component as opposed to a more fibrotic or calcific stage? We are very excited about having this report out in the community to help further understand potential use of this therapy and help patients in this very challenging and difficult to treat condition. Thank you for your interest.
We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.